Good evening. My name's Sanjay Khurana. I'm a board-certified spinal surgeon. I work out of Los Angeles, California, with offices in Marina del Rey, Manhattan Beach, and I work out of Beverly Hills and Santa Monica. We recently completed a venture with HOI at our surgical center, and I'm pleased to join the Hoag Orthopedic Institute team, providing comprehensive spinal care. The topic that I've been tasked with this evening is to talk about minimally invasive spine surgery. Some of the salient things that consumers should know about what is minimally invasive spine surgery. Well, let's just define what minimally invasive spinal surgery is. Really, it's achieving the most effective solution for surgical problems of the spine through the least traumatic technique. In our field, that means muscle splitting versus detaching muscles. It means maintaining bony architecture so that post-surgery, your anatomy is essentially unchanged except for what we need to change, which is oftentimes nerve compression. And importantly, minimizing blood loss. And these are the tenets that we use to define what minimally invasive spine surgery is. If you look in the left panel, essentially an older vintage photo of surgeons pioneering surgery. And to the right panel is a photo of myself and a partner doing minimally invasive spinal surgery. It's changed quite a bit from the olden era, and I think largely for the better, thank God. A lot of tools have arisen from the advent of technology. We've used fiber optics, better lighting, as well as using a lot of our procedures from general orthopedics and now translating them to spine surgery. This is a picture of one of the latest crazes in what we do, which is endoscopic spine surgery. Although it's a relatively new component of what we do in spine surgery, it is gaining momentum, and I think over the next several years, certainly over the next decade, this may even replace the gold standard right now, which is really microscopic spinal surgery. Robotic spine surgery. This is a very compelling part of what we do. Right now, robotic spine surgery is really limited to the assistance in screw placement for more complex cases such as scoliosis or deformity type surgeries. This is a really exciting field. It keeps the predictability of screw placement at a very high level. It minimizes the rate of revisions and often leads to more precise and possibly even quicker surgeries. A few examples and some cartoons, some pictures. Essentially in this cartoon here, it shows a technique of a muscle splitting technique. There's books about minimally invasive spine surgery that I've been part of and talking about the process of spine surgery. Oftentimes when people advertise or talk about how big the incisions are, they're referring the incision to the size of a quarter, sometimes a dime. You see commercials, for example, Laser Spine Institute in the past that have shown these incision changes on the left, a large incision, more traditional spine surgery, and a kind of a bikini friendly incision on the right. We've been powered through the use of technology. The microscope has been our friend, using illuminating light sources, using powerful microscopic tools. We've been able to visualize better, perform more precise and more effective surgery. We also use tubes. Here's an example of a tubular dilator that's very commonly used for microscopic spinal surgery. What surgery oftentimes is not is what I think most consumers fear when they think of spine surgery. They think of this example. Please pardon the grotesque nature of this, but it's a large open scoliosis surgery. Minimally invasive spinal surgery is not this. Now, this is not to say there's not a role for extensive surgery. Sometimes in extensive deformities. You have no choice but to open up the spine, decompress nerve roots in the most effective way, and put instrumentation in the more traditional ways as depicted in this picture. But minimally invasive surgery is not this. What are the benefits of minimally invasive spine surgery? Let's go through them. Less pain post-surgically for a hastened recovery, especially in the short term. Oftentimes, we've been able to do these surgeries, and in fact, frequently, we do them in an outpatient arena where a surgery can be done in the morning, and oftentimes in hours, they can be discharged. We avoid blood products by excellent visualization, by precise utilization of coagulation, and identifying bleeding when it starts. We can avoid blood products altogether. Minimal scarring, again, this is a product of being very physiologically friendly with the tissues, avoiding a significant amount of traction, avoiding trauma unnecessarily, and just being friendly with the tissues that surround the spine. Achieving long-term surgical goals. I think when I think of minimally invasive spine surgery, one of the key tenets that we can't lose sight of is that despite trying to be minimally invasive and optimize the short-term recovery, avoid blood products, and be physiologically friendly, the most important thing that can't be forgotten is we want to achieve our goals of surgical decompression, surgical stabilization, deformity correction, etc., but not losing sight of that. Well, what are the conditions we treat? There are a number of spinal conditions, and I'll go over some of the more common ones that we treat in minimally invasive spine surgery. Spondylolisthesis is a common condition that we treat where we treat two sliding bones that frequently slide upon each other, the long-term implication of which often is that the nerves become compressed and then trapped, resulting in spinal stenosis. And so this often comes concomitant with the condition of spinal stenosis. Of course, stenosis is what comes next. That's the generic compression of nerve roots that occurs in the spinal canal. Herniated discs. These are common problems where a disc fragment can rupture from the native disc, displacing nerve roots and causing what we know as sciatica, or pinched nerve syndrome. Painful collapsed discs simply occur. That's when you get the generic compression of a disc as a result of wear and tear. It can happen from a genetic predisposition. It could happen from trauma. It could happen from a lot of unknown variables, including, quite frankly, bad luck. Scoliosis, this is somewhat of a different field. We do, using minimally invasive techniques, often correct moderate curves, and by that I'd say roughly 40 degrees or less. There are some surgeons out in the community or in academic centers that will be much more aggressive in correcting more severe curves using minimally invasive techniques. I think this is more of a controversial area in terms of the application of minimally invasive surgery, but it is still an area that we often treat in small doses using minimally invasive techniques. I don't want to neglect the cervical spine or the neck, and one of the greatest revolutions that we've experienced, certainly in my career in the last 20 years, has been the treatment of pinched nerves in the neck, and I can describe some of the techniques that we've used and have been pioneered over the last 20 years. So let's start with a disc herniation. This was actually a patient of mine, and for those of you out there with a queasy stomach, I apologize for the picture on the right. On the left, it's a picture of a patient with a large disc herniation. You could see the abutting structure from that left-sided panel image of the MRI scan. And the corresponding image on the right side, which is called the axial image, really shows that the spinal canal is essentially completely obliterated by this large herniated disc. Well, this patient of mine was entirely incapacitated. The patient was unable to move her foot, had severe pain, and actually had some issues with bowel and bladder, which ultimately became an emergency. Well, through a small incision, roughly the size of a quarter, perhaps I'd say between a quarter and a nickel, we were able to put a small retractor, and we removed the fragments, which when we compiled it after surgery, essentially equaled that pile of material that looks like crab meat. So that's what disc looks like. It's done through a fairly small incision. The recovery for this patient was rapid. It was roughly 4 to 5 hours in our surgical center, followed by discharge home within short order, and virtual complete resolution of the weakness, complete resolution of the pain, and a very happy patient. Spondylolisthesis is a common condition. It occurs more in women than men. This particular condition depicted here is known as a degenerative spondylolisthesis. It occurs when one bone slides relative to the other bone, when you've lost some of the ability to hold that side alignment. And as a result of that, in that arrow, for example, you can see the depiction of the nerve root being squeezed. Now, in this case, there's spinal stenosis as well as a deformity or a slippage known as a spondylolisthesis. And one of the things, even in my career as a resident and as a fellow, we typically treated these with open procedures, making fairly large incisions, losing a moderate amount of blood, putting in screws, manipulating the nerves, and all the things that I mentioned about minimally invasive spine surgery were not exactly heeded. I think we tried our best 20 years ago, but at the end of the day, the technology wasn't there, and we're still learning. Over the last 20 years, we've come up with a number of techniques, one of which I use a lot to treat this particular condition. It's known as a lateral transpsoas interbody fusion. And in this picture, essentially it shows some of the two different types of fusions that we did. In the left cartoon is a traditional open technique where you slide the muscles upon the spine and you insert large screws while the muscles of the spine are essentially filleted open. On the right panel is one of the techniques we use now, where we actually make a small incision on the flank, which allows us to gain access to the disc space. We dilate the disc space, we remobilize the disc space, and then we insert a spacer. It can be made out of titanium, it can be made out of porous PEEK or plastic, and we fill it with biologics, oftentimes not even your own bone, but rather synthetic bone, and that allows the slippage to reduce or realign, and it leads to a fairly high predictable fusion rate, even without the need for screws, although oftentimes we will add screws in the back of the spine through a percutaneous technique to stabilize the two bones together. One of the benefits of this technique also are that oftentimes, and in select patients, you simply put the spacer in, and that leads to a significant decrease in the amount of spinal stenosis that the patient's encountering. And so you can essentially see the distortion and the significant difference between these two techniques. Here's a kind of cartoon animation, essentially, of what it looks like before on the left panel and on the right panel when the spacer is put in. You can see the realignment restored, and you can even see the nerve root, which on the left side is depicted by a red inflamed nerve root, and how it looks better once the spacer is inserted. The name for this procedure, I've described it as a Transpsoas procedure. The company that originally described it as the XLIF technique, or the extreme lateral interbody fusion technique. However, since then, it's been renamed a lot of things by various companies that want to have their own kind of acronym, and it's been known as the LLIF, the DLIF, the GLIF. So you can name them all. They're all the same technique, essentially, of approaching the disc space through the side. The advantages of this technique are minimal muscle stripping, the insertion of a large graft and volume of bone material for predictable interbody fusion, as well as the powerful correction of translation and scoliotic deformities in a moderate capacity. So percutaneous fixation is what I just described. It's instead of making large muscle splitting approaches, we make usually nicks on the back where we slip in screws using this technique really described in this cartoon, and it allows us to avoid the large incisions that often are painful and, quite frankly, more prone to infection and complications. So this has been a great addition to our armamentarium. Depicted on the X-ray fluoroscopy image is the application of several screws that we put in. I'm not sure when this was put in, but we used the percutaneous technique. This is one of my patients that shows a pre and post. This case we actually did in our surgical center. So this patient came in with severe back pain, severe leg pain, and using the lateral interbody fusion technique, or the XLIF, we were able to put a spacer in on the right panel and realign the two bones together, using a technique that took us no more than half an hour. The percutaneous screws we put in were put in through small incisions. Again, took about 30 to 40 minutes. In this case, the narrowing was moderate to severe, and we didn't actually have to manipulate the nerve roots. We just depended on the interbody graft to achieve the large correction. And this was certainly a very nice case for me. Technically, the patient was extremely gratified, and to this day has been one of my most pleased patients. Very happy about this particular case. Spinal stenosis is the description of generic nerve compression in your spine. It's probably the most common thing that I see. In the cartoon described here, you see the spinal nerve roots on the sideways view of your spine, and the red markings indicate compression and inflammation of the nerve roots. On the MRI scan, in that red circle, you'll see typically what we observe when we describe spinal stenosis, which is narrowing of the spinal canal in almost a hourglass phenomenon that has an area of constriction. Sometimes the whole spinal canal is very narrow, and in some individuals it's more focal, where it's just at one or two levels. On the MRI, on the sideways view, or what we describe as the axial view, you can see an example of a normal spinal canal depicted on the left and a narrow spinal canal depicted on the right. So for these techniques, we use microscopes. We use techniques where we put small retractors or tubes, and we essentially decompress the nerves until we're essentially fully decompressed, and we can directly see the nerve roots. We make sure that there's very little bleeding. We make sure there's no compression of the nerves, and they're closed again with a nickel or a quarter-size incision. The advantages that we observe, if I had to articulate what they are, we use high-power magnification, sometimes up to 20 times. We have excellent illumination or lighting. Oftentimes when I do these, my neck doesn't hurt because my neck's in a neutral position, and the binocular vision allows me to look at the spinal surgical site at a right angle without having to bend my neck. We see exquisite tissue detail, which is amazing, and it's just it gives us a lot of confidence when we're completed that we've completed the entire surgery. Also, one thing that can't be understated is the ability for two surgeons to work at the same time and to actually see the exact same subject at the same time. In the olden days, even when I was training, we would use loops on our glasses. We'd both bend our necks and we would look at something describing what we're looking at, and oftentimes we'd be looking at completely separate things. So this gives us a combined common visual goal. The final feature that I did want to talk about that's been somewhat of a game changer for patients is the treatment of cervical disc herniation. In this example here, what you can see is essentially the sideways view of someone's neck. You can see their brain at the very top part of that image. And what we can see in this image is a patient of mine that had a very large disc herniation. You can see that hourglassing, like I describe it, of the spinal cord where that disc is essentially indenting that spinal cord area. These are very painful. Oftentimes they're accompanied by zingers down the arms. They could be associated with arm numbness, weakness. In severe cases, you could have difficulty walking because your tracks that go down to your legs can be interrupted, causing significant paralytic conditions. Historically, we would treat these with a surgery known as either a anterior cervical discectomy infusion, where we took that bump out through the front of the neck and we replaced the disc with a bone graft and plate. Or we'd go from the back of the neck and do what's called a laminectomy, where we'd remove the entire arch of bone to decompress the spinal cord. Those both worked, and they both worked well. However, they came with associated collateral damage. Again, soft tissue damage, changing the architecture of the spine. In the case of a fusion, limiting motion and leading to other levels wearing and tearing. Well, over 40 years ago, in fact, folks were working on disc motion preservation devices. And it's not really until recent, for the past 20 years, that motion-bearing devices in the neck have actually become prime time. In this patient, we inserted something called an artificial disc, and that took the place of the C4-5 disc segment while fully decompressing the spinal cord. This patient is now perhaps 2 years out and has returned to sports, has essentially a pain-free lifestyle, and haven't restricted the patient in any way. Nor do I have a significant concern that another level in the neck is going to be at risk for breakdown. This is, again, an outpatient procedure, probably one of our most common outpatient procedures that we do, that's associated with very little blood loss, rapid recovery, minimal pain, and return to function. One of the main differences from a visual standpoint when you see a patient with a fusion versus a disc replacement is that we don't use collars anymore. We simply finish the surgery and we let them roam. We let them work freely. I typically don't let them return to sports for about 4 to 6 weeks, depending on the type of sport. But this is really a game changer. Has been a very good addition to our surgical armamentarium. A couple examples I just want to show you. I really show the audience just a few very salient, high-level examples of what we do in spine surgery. I oversimplified a lot of the things that we do for the purposes of generating discussion, being illuminating, and just showing the audience what techniques are out there for your back condition that doesn't need to have a lot of fear associated with it. This is another example. This is perhaps over a 10-year-old case of mine in a patient that had a spondylolisthesis that we treated with a lateral interbody fusion that you can see in the disc space there. In this case, instead of using screws, we decided to use a clamp, which avoided a lot of the far stripping of the muscles of this patient. Another example, an early example that I used was a patient with a minor scoliosis, 2 levels of disc collapse, and 2 levels of treatment through a lateral interbody approach with the supplementation of 1 set of screws. This patient, again, this is one of my earliest patients I did, still sends me postcards from their vacations and Christmas cards and so forth, showing just how gratified patients can be when you can fix their condition through a fairly limited means. These outcomes are durable, they're effective, and they're safe. So to conclude my high-level talk about minimally invasive spine surgery, mostly it's here to stay. It's, in my practice, it really is my gold standard. The majority of spine conditions that we treat have a minimally invasive pathway, and you should ask your surgeon about that, versus a more traditional laminectomy or traditional spine and screws approach. Is there a minimally invasive pathway to treat your condition? But remember, when you're talking about minimally invasive, don't confound minimally effective. This really has to be maximally effective. And we want to find the least invasive solution to achieve that goal. Most new technologies that are out by industry do incorporate techniques of minimally invasive spine surgery. There are techniques that I mentioned at the beginning of this talk, using endoscopy, using the robot, that I know will be much more commonly adopted. I think right now it's in the early phase of adoption, but within a few years, I can see my practice even changing further, just like it has in the past 20 years. I'm a friend of technology. I'm a friend for change. I do think the most important goal when we use these technologies is to help our patients with faster recoveries, with more effective recoveries. So with that, I want to thank you for your time. I guess I put one more slide in here for the use of stem cells and PRP and a variety of biological techniques. These are also in the mix, but probably out of the scope of this particular talk. So thank you so much for your time. I think I got some questions too. All right, I got several questions I'm going to read from the audience. One is, will having a lumbar microdiscectomy prevent you from being a candidate for artificial disc replacement later in life? That's a great question. I'll respond to this question in the following way. The index clinical trial for the ProDisc L, when patients were being enrolled for the actual artificial disc replacement, included a subset of patients that have had microscopic discectomies. Interestingly, in that subset of patients, if you look at the patients that did well, I think in the artificial disc replacement study, to get technical, it was a non-inferiority study compared to fusion. But in fact, the patients that had prior microdiscectomy actually did better after getting a lumbar disc than those cohorts that hadn't had a microscopic discectomy. So for what it's worth, the trial seemed to indicate that you would not be that would not interfere or interrupt your ability to be a candidate for artificial disc replacement. I hope that answers that question. That's directly from the clinical trial. Okay, so can you elaborate on the use of minimally invasive surgery? It says MIT, but I'm assuming it means minimally invasive spine surgery for scoliosis. And how long is recovery generally? So number one, I should answer, it's a good question as well. When you're talking about the use of minimally invasive spine surgery in scoliosis, it really comes down to magnitude of your curvature and the extent of the deformity. I think even the most avant-garde, cutting-edge, minimally invasive spine surgery, I know a lot of them around the country, would argue they could treat significant curves, 60, perhaps even 80, 90 degrees with minimally invasive techniques. But I think the majority of regarded spinal surgeons that do scoliosis, and I'm more of a, for big deformities, I'd probably use more traditional techniques, but combining where I can minimally invasive techniques. I think there can be a use of both in the maximal effectiveness of that particular surgery. If the curve is a small one, so I'm talking maybe 40 degrees or less, there's probably a more realistic application of the use of these techniques, which allows for powerful correction of the scoliosis in both the front and back plane, the side plane, as well as the rotatory plane. So I think it still is a great technique for scoliosis cases in certain parameters. The recovery really depends on how quickly the bone is going to heal. So when you're doing any sort of fusion, it typically takes anywhere from 3 to 6 months to heal for bone to remodel and unite with the other bone. When you're uniting multiple levels, for example, 4 to 5, 6, maybe 10 levels when you're doing a deformity, you're really looking at 6 months to a year for a full recovery. But in terms of being active, walking, being a member of your community, and going back to work, nowadays, in my experience, 4 to 6 weeks for big deformities is what I'm usually comfortable with. For the larger deformities, depending on how much pre-morbid time, like how debilitated one's been leading up to surgery, has a really big impact on how much time it's going to take to get back to the community or get back to work. So a difficult question to give you the specifics on, but scoliosis will, among what we talked about, take the longest period of time for the full recovery? Great question. So next question. If I had a fusion at L3, 4, 5, and S1, am I a candidate for the types you have discussed if I'm still experiencing lumbar pain? It's a great question. I think, number one, there's always an opportunity to get a second opinion. I think, broadly speaking, if you've been fused at multiple levels, I think a board-certified, fellowship-trained surgeon would look at your films, look at your case uniquely, and try to determine what the source of your pain is. Is the fusion complete? Is there any loosening of the hardware? Is there a transitional problem at a different part of your spine? So there are a lot of potential explanations for why you're still having pain. Perhaps your curvature was not matched to the right pelvic parameters, and that could be having an impact on your back pain. So it's hard to answer that question specifically. I would tell you to always don't hesitate to get a second opinion. I tell even my patients, if there's any sort of uncertainty, don't hesitate. This is your body. You're your best advocate. See as many doctors as you can. Hopefully it doesn't confuse you more, but at least get some opinions in regards to what the standards of care could be for your particular condition. But short answer, I think there are opportunities for a patient with a multi-level fusion to see another doctor and consider minimally invasive techniques for possibly additional surgery. All right, this question reads, what is the first step to determine what course of action is best? An appointment with one of your sports medicine doctors. Great question. I think number one is it depends on how bad your pain is and what types of symptoms you're having. If it's just achy pain, kind of back pain, backache, and it affects your quality of life in a material way, but perhaps not enough to contemplate surgery, and you just want to get a look at it, your general doctor is a great resource. Your doctor will guide you to a physiatrist, a physical therapist, and these are probably the most reasonable ways to initially determine how you're going to respond to the most conservative intervention. If you have features of pain like numbness, weakness, loss of your bowel and bladder function, atrophy, significant deformity where you're walking in a way where your head doesn't fall over your pelvis, or you're walking funny, you feel that there's something mechanically or neurologically going on, I think it's reasonable to try to make an appointment with a spine surgeon directly and really get an opinion from a spinal doctor as to what's going on once the appropriate imaging is obtained. Oftentimes I'll skip the line and I'll get an MRI scan on a lot of patients to see what's going on at the level of the nerves, the level of the spinal stenosis, deformity, etc., and make a prudent recommendation. I think what you'll find in most spine surgeons is that despite surgeon being in our job title, we often will find the least invasive way, even without the use of surgery, to get a patient better. And I think that's just part of an algorithm. I don't think any of us like to hop to surgery first. We usually like to exhaust everything that's non-operative. In conditions where you have neurological deficiency or weakness or paralysis, obviously it's more of an emergency. So we will deploy more surgical techniques if we feel that's the most prudent way to get you feeling better. But I think don't feel shy to go directly to a spinal surgeon, a physical medicine doctor, or a pain management doctor if you're having symptoms that are unmanaged or not satisfactorily answered by your general doctor. It's a great question. Thank you. With that, thank you so much.